Okay, good afternoon. Welcome everyone, welcome back. Thanks very much for participating today and for everyone for traveling so far. And I'm going to be moderating, Barbara Koenig, as you know from before, I'm going to be moderating the Societal Concerns panel. So the End-of-Life Option Act includes multiple safeguards and will undoubtedly be the best option for certain patients. However, there are potential harms as well. So what are they and how can we avoid them? And we will consider the societal concerns raised by the End-of-Life Option Act. I'm going to introduce the four panelists to my left, who will each speak for 10 minutes, responding to questions which I sent them ahead of time. And then we'll open it up for discussion. So similar to what we did before. I'm going to introduce everyone right now for the sake of time. And I can't seem to get this to go down. There we go. It's a little better. So starting from your right, Rosemary Garland-Thompson is Professor of English and Bioethics and Founding Director of the Disability Studies Initiative at Emory University. She works in the fields of cultural disability studies and health humanities, and in her work she wants to call attention to disability access, equity, and issues of identity. Next, we'll have Catherine Brown-Saltzman, my fellow nurse and also an ethics person, and she was the co-founder and is now the co-director of the UCLA Health System Ethics Center and is an assistant clinical professor at the UCLA School of Nursing. Her clinical practice has been in end-of-life care. She told me that it was for quite a long time. I won't say how long. And her work is now focused on ethics, including moral distress of health professionals. She's been a leader of a major national nursing ethics conference convened at UCLA for the last several years. Next, Clarissa Kripke is a physician at my institution, UCSF, where she's the clinical professor of family and community medicine. Dr. Kripke directs the Office of Developmental Primary Care, the mission of which is to build the capacity of the healthcare system to serve adults with developmental disabilities. She serves as the primary care doctor for a panel of medically fragile and behaviorally complex patients. So clearly those two individuals are going to help surface some of the issues for certain communities in the state. And then finally, David Kaloran, to my left, asks that you also, he had a handout on the table that he's going to be referring to, so if you could pull that out while you're waiting and before he speaks, he would appreciate that. David is a partner at Squire Patent Boggs, an international law firm. A trial and appellate lawyer, David specializes in product liability defense. But the main reason he's here today is that in 2012, his wife Maureen was diagnosed with ALS, and David spent 5 years fighting legal battles to stop the healthcare system from depriving his wife of the care she needed at home so that she could live in comfort and dignity in her final months of life. Based on that experience, David founded the ALS Action Foundation to educate people about resources available to ALS patients and their families. So let me share with you, and I should say one person is going to use slides, and they promised that would help them stay on time. So we decided to go with that. And these are the questions. So the first was to please address the potential devaluation of certain lives, such as the disabled or the socially and economically marginalized. Second was to please address the End-of-Life Option Act's impact on the processes of natural death. For example, the impact of a symbolic hope for a quick fix. We talked a lot before about the issue of how this new choreographed kind of death, maybe a new kind of rite of passage, would become a new phenomenon. So that's going to be an impact that's beyond that of harm to individual patients. The third question was, many have argued that the introduction of physician aid in dying starts us down a steep, slippery slope. So I asked the panelists if they had specific suggestions about how to plan for and avoid negative downstream societal consequences, or how to facilitate positive consequences. And then finally, I also asked the panelists to address the exercise that you're also been asked to address in terms of putting your hopes and concerns and on the colored pieces of paper and putting them on the wall. and to see, and hopefully then that will move us forward in that conversation as well. And of course, there might be other issues as well that they'll bring up. So I'm going to start, I'll start with Rosemary.
Thank you, Barbara, for this opportunity, and thank you all. I'm really quite delighted to be here. I am spending a sabbatical year out here in California instead of at my university, which is in Atlanta, Emory University. But I'm also a senior professor of English and literary studies, and I'm a junior bioethicist. So what that means is that I am bringing to our set of considerations here and our set of considerations in the larger field that we think of as bioethics, I'm bringing, dragging with me, if you will, a vocabulary that comes from the humanities and that comes from cultural studies more than a vocabulary that comes from medicine. I'm very grateful to be in environments like this because I'm trying to learn how to translate the way I talk about things into words that that are appropriate and accessible to my new audiences as a bioethicist. So thank you for letting me turn this whole thing into a language lab. In order to address the questions that Barbara asked us to address, what I wanted to do is not so much to focus close up on the actual California law, but rather to back up a little bit more broadly to a bit of a wider focus on the concept, the consequences of what we call physician-assisted dying, or PAD. The Hastings Center uses that particular term, and to think about it a bit from the perspective that I'm able to offer. And so I wanted to start with the place that people who work in the humanities and in cultural studies work, and that is with cultural analysis and with narrative and story. So I wanted to start with the caregiver perspectives that we heard on the session earlier today, because I want to suggest that what those stories, what those narratives offer us, and narratives like those, is a way to think about the exercise, the exemplary exercise of one of the most fundamental principles of liberal modern societies, and that is the concept of liberty, the concept of freedom, the concept of choice, the concept, and these are the terms we tend to use more in bioethics and in medicine and in law, and that is self-determination and autonomy. That citizens, or liberal subjects, if you will, have the right to self-determination. That kind of liberty is crucial to who we are. And it's very important for us to be able to have examples, and there are many examples, of course, across all environments, if you will, or sectors of the society, to exercise these rights to liberty. We put that in conversation, however, with another important principle of liberal societies. And when we think about, and we talked a bit about this morning, when we think about how what we're calling physician aid in dying, when we look at how that has developed in the Netherlands and Belgium and in Switzerland, what we're seeing is a conflict between self-determination and autonomy as a principle, organizing principle, a basic right, if you will, of liberal societies, and a concern for the common good. So most of us understand the logic and support the principle of self-determination and liberty in exercising these options, if you will. But we're worried a bit about the way that, let's say, the Netherlands and Belgium have moved from what began with the kinds of stories that we heard this morning and have moved into, say, involuntary euthanasia, child euthanasia, which is not practiced very often. And also that 4% now, we saw the charts of the people who die in the Netherlands die under this practice, which is not exactly a law, but it's a set of practices. So what we see here is a conflict between an important liberal principle, that is self-determination and autonomy, and another important principle, and that is the common good and the concept of equality. Because, of course, what is happening in the Netherlands and what could happen and what people worry about here is that these practices will intensify or even augment an environment, a climate that authorizes the differential valuing of citizens. In other words, that it will encourage a climate which says this kind of life, a life imagined as a life of suffering, a life imagined as a low quality of life, a life imagined or understood as a deficit model of existence, is a less valuable life. And of course, this is what disability rights people worry a lot about. The problem is that we don't really have a very robust understanding of what the common good is. And what I would want to offer is for us to think about how the common good might be expressed in egalitarian principles that are carried out in agreements, arrangements, covenants, I call them, that arose out of the civil and the human rights movement, such as the Declaration of Independence, which of course comes earlier, but the United Nations Treaty, for example, on the rights of people with disabilities, which stresses autonomy, but it also stresses the equal valuing of all lives. And to think about conversations that might take place that would bring these kinds of perspectives into the conversation. So I want to shift, if I can, in my last 2 minutes, to what Barbara also invited us to talk about, and that is hopes. What I have been trying to think about, to theorize. Now, in cultural studies, we do a lot of theorizing. In bioethics, which is an applied field, we think about policy and practice. And I'm a little rusty on moving from one to the other. But what I'm trying to imagine is developing within medicine, but perhaps within a variety of institutions, what is a kind of nascent initiative in medicine, and that is the concept of cultural competence. And what I'm trying to imagine is what disability cultural competence might look like and how it might be institutionalized, how we could train people who are both patients and healthcare practitioners in the history of people with disabilities, in disability culture, disability arts, disability technology, the development of technology, the use of technology that makes it possible, and, of course, disability rights. This kind of knowledge, this kind of competence for us all to have in living with disabilities, living a life with a disability, could help us better understand small things. This morning, for example, the first speaker, I think, spoke about, in one of his case studies, one of his vignettes, he spoke about the computer engineer, I think it was, who could no longer type. And he said, a computer engineer that can't type has a very low quality of life. Well, disability cultural competence would be able to let that man know that one can continue creating text, one can continue working with technology without being able to type. People with disabilities, like me, never type, but I am able to have a very high quality of life. Now, not at the end of life, of course, are people going to change the way they do things and be able to adapt and adopt technologies or bring ADA suits or live in a world of disability pride. But if we all tended to understand what living with a disability means in different ways, if we were able to come to a kind of disability cultural competence, I think it might give people simply a different way of understanding these ways of being.
Great. Rosemary, I think
Yes.
that was a
Thank
logical stopping point. I'm going to move us on to our next
Period.
panelist. Thanks.
Thank you.
Whoops. Thank you, Rosemary. I hope I can follow through. I actually want to humbly, truly humbly, share with you some thoughts and ideas. And I really felt privileged to be able to speak to this because this is what I ruminate about at 4 a.m. in the morning when I'm thinking about these things. Like, what is the big picture and what does this mean, not just for the individual, but for us as a whole? So thank you for letting me share this, and bear with me. I truly say this in terms of coming from a very humble place as I struggle. So I think the first thing, as I was thinking about this, was the idea of boundaries. And the fact that, let's just look at the definition, that which serves to indicate the bounds or limits of anything, whether material or immaterial, also the limit itself. And I think in terms of medicine, and certainly all of healthcare, that we are struggling with boundaries, ethical obligations, professional obligations, legal obligations, and the idea that rules help us to flourish as individuals and a society. And so we hear Rosemary talking about this idea of freedom and still also broadening that to the other aspects of a good life and how we flourish. I can't see this, so I hope I'm on. So in terms of intent, a good death. So if we think about in this room, even as we struggle with what does a good death mean, the intention becomes the boundary, essentially, in the care of the dying. So we have two practices, the skillful pain and symptom management, and the intent of not hastening dying. And then when we move into physician-assisted death or physician-assisted suicide, we're looking at assisting death by prescribing a lethal drug. And the intent is, in fact, ending the life at the request of that person. So certainly not euthanasia, but the person coming forward and saying, I need to end my life. So very different intents. And then when we think about boundaries from a perspective of beneficence to do only good and non-maleficence to do no harm, the tension even there. So our 2,500-year-old history of not hastening dying, and yet coming to this place of hearing this autonomous wish of the patient to say, please hasten my dying. Let me hasten my dying. We also see the AMA Code of Medical Ethics that says that physician-assisted suicide is fundamentally incompatible with the physician's role as healer. And we also see this in the American Nurses Association as well for nurses. So this is where I think I really struggle. And Trust, we know, requires boundaries. The minimum, and this is Daniel Samacy's lovely quote, the minimal ethical conditions that establish the bounds necessary to sustain trust. I will not divulge your secrets. I will not have sex with you. I will not kill you. And we could even see humor in that, couldn't we? But it really is about boundaries. So then we look at the limits of autonomy. Autonomy is not, in fact, it doesn't equal unlimited freedom for either the patient or the professional. The limits, autonomy is, in fact, not always honored. So we see situations in healthcare, whether it's the request for antibiotics, for a viral infection, female circumcision, a surrogate asking that we, in fact, withhold pain medication at the end of life in a patient who no longer has capacity. And yet the family says, we want them as awake as possible. And we put limits on that and we say, no, because, in fact, we have an obligation, an ethical obligation, to provide pain relief. And then we have also the induction of labor for the convenience of sense of control for women who are delivering. And we say, maybe we're not going to induce now, maybe we're not going to do a C-section because it's not in best interest of the patient or even the baby. So this idea of unbounded autonomy, requests for futile, non-beneficial, medically inappropriate, and harmful treatment. We have seen this grow over the years to the point where we are all struggling, right, in terms of how do we, in fact, provide what we consider reasonable medical care at the end of life. Not futile treatment, but beneficial, good treatment by our standards, honoring unbounded autonomy. We've gone that route. We've found ourselves in trouble. We recognize the harm to patients, their families, and the professions themselves, as well as the professionals, by providing that requested inappropriate, harmful treatment. Futility policies then developed, limiting non-beneficial treatment. And essentially, I think now as we shift into physician-assisted death, we are going to be up against this tension and this struggle of how will the public trust us to both limit autonomy at the same time that we, in fact, are hastening dying. So there's going to be this tension, not only in terms of futile treatment, but certainly even in terms of appropriate morphine drips, appropriate end-of-life care, this fear, essentially, that we may be hastening behind the scenes, that we may even be euthanizing. The power of the healer, trust already compromised. So we know that physicians, by the Gallup poll, even in 2016, were really quite low, 65%, I believe it is. And so we again hear Daniel Samacy. He says, we physicians should not want, nor should we be given such power. And so I think that as we hear this small percentage of patients, how do we honor them but not put physicians in harm's way? How do we help them to honor their tradition and their profession? Truth-telling generates trust, and honesty, intent, and language are important. So we know in California that the legislative process actually failed twice in referendum, and then was enacted by a legislative coup during a special session on the budget. That's not a good way for laws to be passed. And then we see the death certificates, both here in California and in Oregon, that we don't use the language of what actually was the cause of death. This worries me. Why are we covering that up? If we believe that this is a good and right thing, then we should be able to put it with honor and dignity and be proud of the fact that this is what we are doing. And if we really believe this is the morally right action, then that should be on the death certificate, not only as a way of acknowledging the goodness, but also of actually being able to, I mean, we always I mean, think about it. When have we ever not put down on a death certificate what actually is happening? So we see here that it feels like deception to me. It doesn't feel right. It's that little voice that goes, what is going on here that we can't honor a truth? And then even the aid in dying language. I think when we use that language, and I'm not sure what language to use anymore, quite honestly, but when we use that language, what we're doing is we're diminishing all of the good work in palliative care and hospice, right? We are all aiding the dying when we do good symptom management, when we provide spiritual care and psychosocial care. We are all aiding the dying and their families. That's part of what we do. So to use that language for physician-assisted death feels like we've just shifted this in a way, again, that we're not honoring a truth. And I'm in ethics, and I think truth is really important. So how did we get here? I think we have, all would agree, we have a prohibition against harm. We value autonomy. We value a good death. We've seen overtreatment of terminal disease leading to miserable states and difficult deaths. We historically have had a failing in good palliative care. And all you had to do was hear all through today, to hear our families and the struggles, that the historical memory of other family members dying in terrible pain and suffering. We have failed, and we have continued to fail. And not because we haven't tried. Part of it has been an economic factor, that we have not actually had the funding, the adequate funding, because end-of-life care has been from its beginning about cost savings. And that has ultimately led us to a place where we can't provide necessarily the best care. I think we also heard about the concerns about suicide contagion, and we've also heard, Rosemary brought up the concerns about euthanasia. I think that all of this is truly something that we can't just push aside, and we have to begin to really think about what are we doing. I think ultimately the consequences, it really comes down to trust. It's critical to the healing relationship. When it's broken, it affects all future interactions with professionals and the professions, especially when one is vulnerable. This often becomes passed to the next generation. It doesn't stop at that bedside. When I'm dying and most vulnerable, can I trust that you will not hasten my dying, that you will not use euthanasia? You will not let your fatigue, your helplessness, or your pain and witnessing my suffering interfere with your caring for me.
Catherine, I'm going to ask you to just wind up in a sentence or two, if you don't mind. Thanks.
Absolutely, I'm there.
Okay.
I think that we have to essentially respect the goals of medicine and nursing, of healing and not hastening death. I think we have an obligation of honoring and even valuing the process of dying, of suffering. Like birth, we need to avoid medicalization of it. And I will continue when we have questions.
Great,
but thank you.
Thank you.
Very good.
David.
What's it? Okay, great. Thanks. Thank you so much for giving me this opportunity to speak to you and to be willing to engage in this conversation. A substantial portion of the general population and of physicians have come to believe that some lives are so undignified, that are so suffering, burdensome, dependent, painful, limited, meaningless, or hopeless, that they would be better off dead. And therefore it's respectful and merciful to help them die. That message is not confined to the exam room of people who are making a request for a lethal prescription. And it is a societal concern for people whose lives at baseline are considered, are devalued in that way. To illustrate my point, let me tell you a story about one of my patients. He was a 25-year-old man with a significant disability. He developed a pneumonia, but he was not dying, and he had no terminal illnesses. It was treatable. He was in recovery, but his recovery was extremely slow. The hospital administration, and this is not UCSF, was under extreme pressure to reduce length of stay for financial reasons. It viewed offering hospice earlier in the course of care as a way to accomplish that goal. And so without the consent of anyone on the treatment team, his family, or me, the hospital administration sent a palliative care team to his bedside and were so aggressive with the patient's mother that the mother called me in tears. They put a note on his chart calling his condition grave and recommending hospice for him, and this was while he was continuing to improve. The acute part of his hospitalization was over. He was improving every day. It was just very, very slow. They held a team meeting where the hospital personnel argued with the attending physician and with me and with his caregivers and families that we should change his goals of care because further treatment for the pneumonia would not change his underlying neurological condition. The hospital administrators then called the attending physician into meetings where they pressured him to make more use of the ethics committee and palliative care team on his patients. And then the chief operating officer of the hospital called and started to yell at me for not supporting a change in his goals of care. The patient fully recovered to his baseline, and 2 years later, he got another pneumonia. He arrived at the emergency room with a pulse that we had done together, indicating his preference for a full code. While the patient lay in the emergency room struggling to breathe, instead of getting intubated, the ER doctor took the time to call me and again yelled at me for not having an advanced directive conversation with him, by which he meant that I hadn't done a proper job counseling the patient because his pulse would have indicated do not intubate had I done that. He sincerely believed that it was unethical to treat him because of his disability. This story isn't unique, and the problem isn't new. I get a request for help with a situation like this about twice a week, and most people with serious disabilities can tell you of at least one story where a health professional said or did something to devalue their life or deny them access to standard care. This patient wouldn't have been eligible for aid in dying. There was no lethal prescription that was requested or prescribed, so why am I bringing it up? A substantial portion of physicians and the general population have come to believe that some lives are so undignified, suffering, burdensome, painful, limited, meaningless, or hopeless that they would be better off dead, and therefore it's respectful and merciful to help them die. Aiden, this conversation reinforces and destigmatizes and normalizes this belief, and it's a threat to my patients, and one that that's very personal, because twice a week I'm fighting one of these battles. Our first responsibility is to do no harm. And I want to talk a little bit about some of the other questions that you had. How do we avoid the negative societal consequences of physician-assisted suicide? How do we facilitate a more positive consequence? Well, doctors have a lot of influence over the cultural narratives. The implementation of the End-of-Life Option Act doesn't have to reinforce these ideas about the values of some people's lives. But I would say that the awareness of the medical profession about how ability bias creeps into and goals of life conversations and end-of-life conversations needs a lot of work. My most recent article where I talk about this and talk about common scripts that people use when they talk about goals of care conversations and end-of-life conversations, and how they convey pity and abandonment and other disrespect. without intending to, are outlined in that article. So you can take a look at that if you want to maybe raise the awareness a little bit about how goals of care and end-of-life conversations hit the ears of vulnerable populations, especially people with disabilities. We need to examine what we believe and the scripts we use. And I want to talk a little bit about some of the language that you hear today and that you hear in general when people are talking about this. Let's talk about suicide as death with dignity. You brought up the whole aid in dying is devaluing the other ways in which we help people and that we care for people, and that caring for people in other ways than medical ways is not abandoning them. And death with dignity is the same type of thing that we heard that suffering, there were examples of suffering that if you are incontinent, or if you need assistance, or if you need to have a mobility disability and need to, that you're no longer yourself. That you're just a shell of a person, that your life is no longer meaningful, that you're no longer a person. That kind of description of, like, most of my patients have those characteristics, and then the dehumanization after that. And then to talk about having a disability as being an undignified way to live hurts my patients. It hurts people with disabilities, and we need to be really careful about how we talk about what it means to live a dignified life, and not confuse living with a disability with living an undignified life. I want to talk a little bit about pain and suffering. Pain and suffering are not inevitable with terminal illness, but they can certainly be a part of it. They wax and wane. They can be overwhelming at times. But someone's suffering doesn't define a person. It doesn't define a person. And they don't become less of a person if they're suffering. In fact, sometimes that's what helps people focus on what's really important. That I don't wish pain or suffering on anybody, certainly, but we shouldn't assume that it has no value. Life without challenges is not necessarily more meaningful, and the whole narrative that I think that's promoted both by some of the language that's used around physician-assisted suicide and around hospice is that a good death means being at peace and going willingly and doing so quickly without any signs of distress or struggle. But those aren't the only options, and they're not the right ones for everyone. And they don't necessarily lead to the most meaningful final months or days of life. But public policy, like you mentioned, doesn't necessarily financially support other options. And so we should think about what those other options might be. And I'm getting short. I have a lot to say on this topic, but we should really think about the medicalization of death when we talk about options other than lethal prescriptions. The discussion has been almost exclusively medical model. It's been almost exclusively palliative care, hospice, access to a nursing home or a home health aid. And if you looked at why people are choosing the lethal prescriptions, lack of access to medical care has not been the issue. People are worried about losing autonomy. They're about being institutionalized, about being treated as an unperson, about losing their personhood and their self-direction and their control over their life. And we don't have to do that to people. And I think that some of the lessons, my hope is that the disability community has learned how to do this well and has learned how to do this right, and we can teach you how to live well with loss of function. And I hope that this group will be open to learning about that.
Thanks. I'd like to second all of that. Thank you very much for having me here today. You're probably all wondering, what's a product liability lawyer doing addressing this crowd? And it's not because I wandered into the wrong conference, although it feels like that sometimes. The reason is my wife had ALS, which is the #2 diagnosis of patients who request aid in dying. And we have a problem in that the norms of disclosure to people with ALS about their end-of-life care options is reliably bad. We need medical clinical guidelines about the care that's available to end-stage ALS patients, and I'm looking for volunteers to create a working group for creating those clinical guidelines. I cared for my wife since she was diagnosed in 2012. Most of you know ALS has no known cause or cure. It leaves you paralyzed completely, unable to speak, but with your mind intact. The average life expectancy is 3 to 5 years. So when she was first diagnosed, she kept saying, well, when she was first diagnosed, she asked her doctor, "How will it kill me?" And he explained to her that the muscles around the lungs get weaker, and then people with ALS die of respiratory failure. And she kept telling me, "Take me to Oregon, take me to Oregon." But after the initial shock wore off, she chose to make the most of the remaining time that she had left. The condition progressed quickly. In less than a year, she went from cane to walker to wheelchair to power wheelchair. She needed help with all of her activities of daily living. And it was and I had to work full-time in order to support her health care. It was very hard to find, train, and keep hired care workers. We had at least 8 of them quit on us without notice. And whenever a care worker quit and we struggled to train a new one, my wife would again talk about wanting to die. But her outlook always improved after the new care worker was trained and did a good job taking care of her. And so basically it was like she was in a revolving door of deciding she wanted to die and deciding she wanted to live. I want to die, I want to live. I want to die, I want to live for 5 years. Our healthcare system has no clinical standards for caring for people with ALS. I had to fight for a lot of her medical equipment for her to have comfort and independence. She talked with her friends who visited often with a computer that she controlled with her eyes. We went to the movies, we went to ball games, we went to national parks. She went to the voting booth every election and voted. She sent messages to Congress. She did all of this while completely paralyzed. When Kaiser delayed getting her a lateral acceleration mattress for weeks and weeks and weeks, every night she was in excruciating pain from pressure on her tailbone. One night she begged me to smother her. And that's when the gloves came off. I filed a criminal complaint against Kaiser for abuse of a dependent adult and began a series of legal actions to get her the care that she needed. What I found was that the state doesn't enforce abuse of dependent adult laws who are on home care. They only do it in nursing homes. And so I had to go to outside channels to get the equipment that she needed. And every time she lost a new function, she said that she was scared of choking to death. Through my own research, I found something her doctor never told her, which is that people with ALS don't choke to death. As the chest muscles fail, the body starts retaining more and more CO2, and you get sleepier and sleepier, and eventually you fall asleep and just don't wake up. And so when I told her that, she still feared dying, but at least she didn't have to ever fear again about choking to death. Unfortunately, we have no standards that require doctors to tell people with ALS that their prognosis is for a peaceful death. And most ALS patients think that they're going to choke to death because of that. When she had trouble swallowing, she got a feeding tube. When she couldn't clear her throat, she got a tracheotomy so that she could be suctioned. These measures greatly improved her quality of life. When her life expectancy was 12 months, she went on hospice. The hospice offered her 1 home health aide visit a day, Monday through Friday, and 1 weekly brief visit by an RN. And they told me that for the remaining skilled care, 150 hours a week, one-on-one skilled care that she required, that was on me. And I said, why isn't hospice providing shift nursing care? And the reason is ALS patients are told, they're virtually all told, that hospices don't provide shift nursing care or evening and weekend home health aide care. Instead, ALS patients are given a list of elder care providers, and they're told, good luck finding qualified, reliable care workers to take care of your patient. She was told that if she needed around-the-clock nursing, she belonged in a nursing home. Now, many people with ALS would rather die than be warehoused in a facility to stare at the ceiling before dying from an infection from other patients. As a society, we can do better to care for people who have ALS. I handed out everyone fully informing ALS patients. Can you please open that up to the first page of text, which is page 2. So the question is, if a patient is not, this is under the End of Life Option Act, if a patient is not fully informed about his or her prognosis and feasible alternatives or additional treatment opportunities, is a prescription for aid in dying drugs permitted? The answer is no. It states clearly in the Act that the prescription cannot be made unless the patient has made an informed decision, being fully informed about their prognosis and the feasible alternatives, including additional treatment opportunities. Next page, please, page 3. What's the test for determining what information has to be divulged? I already read that to the group. The test is it material to the patient's decision? Does it matter to the patient? Next question. Is a patient's signature on the End of Life Option Act short form consent form enough to prove the patient was fully informed? The answer is obviously no, according to the Supreme Court. So, next page, please, page 4. What is material to an ALS patient? In other words, what information must, under this law, be provided to them when they're being counseled about end-of-life options? First, all ALS patients are concerned about whether their prognosis is for a peaceful passing. And all the research shows that the death in the majority of cases is very peaceful. At the bottom of page 4, you'll see that in Europe, they actually have a physician's checklist for end-of-life care for ALS patients that reminds the physician to advise the patient of this fact. We have no such checklist in California. Next page, page 5. What else is material? What matters to ALS patients when they're asking about end-of-life options? They care about the level of home care that they can expect to receive in the final stages. They want to know, am I going to be taken care, can I be taken care of at home? Will I be provided nurses? Is it going to be too much of a burden on my family? We sought clarification from the Department of Public Health, and there's a copy of the letter there which said that it's wrong for a hospice just to give the patient a list of elder care providers, and that if they need tracheal suctioning or medicine through a G-tube, then licensed vocational nurses must be in the care plan. Next page, please. The rule for hospice coverage is that hospices are required to provide virtually all the care that's needed by terminally ill patients. Next page, please. Here's a ruling on page 7 from the Department of Managed Health Care stating that for an end-stage ALS patient, home health aid services during the evenings and weekends twice daily is medically necessary in this clinical setting. So that hospice was ordered to provide home health aides on the evenings and weekends. Next page, please. Page 8. Another order from the Department of Managed Health Care requiring an end hospice to provide an end-stage ALS patient 16 hours of skilled nursing services per day. That's my wife at my daughter's wedding. We had a hospice nurse with us for that wedding. It's one of the things that allowed her to be able to enjoy that day, which she called a perfect day. And then finally, on page 9, it's another order from the Department of Managed Health Care ordering nighttime LVN services from a hospice when the ALS patient's primary caregiver had to sleep. On the next page, you'll see that under the End of Life Option Act, a provider who does not provide full information about prognosis and end-of-life care options to a patient can be disciplined. Okay? So, I don't think, because there are very few ALS patients that are seen by any individual hospice, I don't think that they're going to be fully informed when they ask about this act, because the level of care or the level of information in education for those doctors is not up to date. And so what we really need is some medical clinical guidelines so that we can publish them, so when someone gets an ALS patient or someone with severe disabilities who's asking about the End of Life Option Act, that we'll have a roadmap of the kind of information that needs to be given to that patient about their other options. So if you're really pro-choice, you need to be pro-choice for all options, not just physician-assisted suicide. You also need to be pro-choice for being cared for at home and having a natural, peaceful death. Anyway, I would love it if there could be some doctors and nurses in this room who would be willing to volunteer to be part of a working group to develop those guidelines. Thank you.
I know I already have asked one question. I forgot to introduce myself. My name is Mark Blight, and I work at Los Angeles Medical Center with Kaiser Permanente. I thought this panel was fabulous. It's a little disorienting because there's a lot of different passions, and they are different. And that's one of the things that I want to ask about. I want to ask the panelists if there was a way to address the concerns that you raised fairly, let's say, but not uniformly, meaning that the concerns you have are distributed across different groups. So one way to deal with them is to make everything uniform according to the different positions you have, but we find that politically difficult. So if the concerns you have could be addressed fairly within the enclave of concern you have, then would you agree that the option for people who wanted to have physician aid in dying or physician-assisted suicide would be equally appropriate within that enclave?
I think.
Are you saying that if we could eliminate all prejudice and unconscious bias and lack of resources and everything in a magic world that doesn't exist and never will, would it be okay to offer lethal prescriptions to people with disabilities? Is that what you're saying?
So that's not what I'm saying, but
Okay, no.
but we're getting close.
Okay.
Because is that what you're asking for?
I think what he was saying, can you imagine a world in which it would be appropriate, given lack of extreme prejudice or lack of resources for appropriate care and treatment, would there be situations where these particular panelists would agree that we need to consider those liberty interests, which is what Rosemary started the panel with, which is, of course, that's the tension, the tension between liberty and the protection and the common good.
Can I just say, Mark, I love your question. What I think about is, where's Dr. Isles? I think I'm saying his name right, somewhere here. He did such a beautiful job talking about medicine, right? And how meaningful these encounters were. But what I heard was the reason that these encounters were so meaningful was because he got to step out of the role of corporate medicine and he got to show up as a healer and take time and listen to the patient, his story, the meaning of his life. I think that we are experiencing healthcare today that is badly compromised, and that physicians are being put in a terrible position just about everyday care. And so I'm not sure that this is the time for this, because I think that those physicians, as Dr. Isles talked about the meaningfulness of being able to do this, I think he was talking about the meaningfulness of medicine. And I think we're losing that. So until we change our corporate perspective, if that's even possible, I worry that physicians don't, as was said, don't even have the time to reflect on their practice and what this means globally, and that we compromise medicine for that small percentage of patients that need autonomy and need control. And I'm just, if I had a magic wand, it would be, could we create another format outside of medicine, outside of nursing, that they could access to honor their autonomy, but it not contaminate what is already so contaminated now that I'm not sure we can even find our way back to healing practices.
Well, my view is that you can't have full autonomy unless you're fully informed. Okay, and so that would address my concerns at least. All right, so if we can achieve full information, in other words, if the doctors who are asked to counsel their patients about end-of-life options, and they've got a severely disabled patient, if they've actually been educated about that, they'll be in a much better position to address some of the concerns that have been raised here. But until the medical board actually requires that under their powers, under the End-of-Life Option Act, to amend the attending physician's checklist, to put that requirement in there, we're going to continue to have a problem.
But David, I want to take the moderator's prerogative and push you on that a little bit. Are you saying that just if we disclosed adequately that nursing care is often inadequate and not that we're not willing to provide appropriate services,
No.
that would then be justification
No.
for making a decision to exercise the act? I mean, I'm just getting a little confused.
No. The information that should be provided is what care is actually available. These resources actually exist. I got them for my wife. I got my wife 16 hours a day of in-home shift nursing. She had that on hospice for almost a year. Okay. She had twice daily visits, 3-hour visits, twice daily by home health aides. The resources exist. It's simply a matter of showing people how to get them. And so that requires full information. And if you read the Act carefully, what you'll see is that if you're not providing full information to someone and you make that prescription, it's not in accordance with the Act. And therefore, you've committed a physician-assisted suicide instead of aid in dying. So it is something that should, sure, that's the way the law is written. If you have not fully informed the patient of all of their palliative care alternatives, it is not in accordance with the Act when you make that prescription. So
Okay.
not only can you be disciplined, you could potentially be prosecuted. And I'm not saying that that should happen. The better course is to educate physicians so that they can impart this information to the patient, so that my wife didn't have to be married to an aggressive litigator in order to get the care that she needed. Instead, if she was under the care of doctors who knew what care she needed and how to get it without having me to have to tell them how to do it, then she wouldn't have had the problems that she had. The other ALS patients wouldn't have the problems that they have. And hopefully, doctors would start to understand that people with disabilities are the living, okay? They're the living, and they need to be treated like the living.
I'm finding myself looking at the slippery slope slightly differently. Like if we have as our, looking at the combination of liberty and self-determination, is that if that's where the line is, then could we say we have to give full disclosure to women that are considering abortion because they don't really know what parenting is like and that lifestyle? And do we wait? How many days do we do that? Or a young man with wanted a vasectomy, does he know that what's happening? And I think the answer is yes. We should be we should be doing that. That's all of our prerogative.
Okay.
But I'm just curious about if you flip it and look at what the implications are in other practices where you go with that. And I think we're all on the same page that there are not enough resources for the vulnerable, I hope.
Yeah, so that, I think I'm going to take that as a comment because I think it stood by itself, and I'm going to turn it to our last comment for this session.
Hi, Lonnie again. Let me, if I may, because I struggle greatly with this issue. And I want to take you, if I may, to the bedside in the present tense, because I think that's where many of us live in the end with this End-of-Life Option Act, is these are patients. I have had a number of ALS patients and patients with other neurologic diseases, which I'll sadly put into a similar category, progressive supranuclear palsy, others, where I've turned down patients because the prognosis was vague or because I didn't think they were getting good palliative care, both reasons. And I have literally been called by those patients and said, you know, you need better care, not me. On the other hand, if I can take you back 2 weeks to a patient I had who I thought had wonderful care, ALS rapidly progressive, from the UCSF ALS Center, getting really excellent ALS care, getting wonderful nursing care, home with family, who drove the issue himself to call me to help him to die. And so I'm now faced with, in the construct of an unjust society, doctors who can't pay enough time to patients, et cetera, faced at the bedside, and I'm sort of wondering, what would you have me do in the circumstance where there is an appropriate request, I think, from an ALS patient at the bedside with a thorough evaluation, who I think is getting totally good care, who has made a personal autonomous decision, that's enough?
You're asking me? Well, you know, if they're fully informed, then you've complied with the act. You know, I never ruled out, I always told my wife I would support her whatever decision she made. Okay, so, you know, if anyone thinks that I'm opposed to the end of, you know, physician-assisted suicide, I'm not opposed to it. I'm not for it. I'm not opposed to it. What I am for is fully informing the patient so that they're aware of what all their options are so that they can make an independent, autonomous decision. And then if that person is my family member, I'm going to support that decision 100%.
Barbara, can we move this also to the others? I think it's,
Yeah.
I'd be interested if there's others on the panel.
Others on the panel. I'm afraid we're out of time because we really need to move to our final breakout, but there's going to be lots of time for discussion.